All right. Yeah. So, Lokesh, good evening. Again, good
Hello,
evening. Hello. Hope all well.
good evening, everyone.
Good
From
evening, everyone.
from cold Switzerland, temperature here is below freezing.
Yeah. Hope you're keeping well and warm.
Yeah,
All right. So, without further ado, I think we're just crossed 7. So, we'll straight away go on to our cases. I think we have 8 new cases with one follow-up. Again, a spectrum of complex cases. So, the chat is open. Please feel free to put in your comments and suggestions for our cases. With that, I'll hand over the sessions to Ames Nagpur and Dr. Apurva or Dr. Shikha. Over to you.
Yes, sir. A previously healthy, developmentally normal 17-year-old girl child, firstborn of a non-consanguineous couple, presented to us with complaints of headache and vomiting for 2 days and altered sensorium for 1 day. The child had a trivial fever and mild upper respiratory symptoms for 1 week associated with on and off non-disabling headache. Before the onset of severe headache and vomiting for 2 days associated with complaints of blurring of vision, and she subsequently became excessively drowsy with reduced interaction, eventually becoming non-verbal, not opening her eyes and showing no meaningful responses. There was no history suggestive of any seizures, no history suggestive of any focal neurological deficit, and no contributory etiological history was obtained. There was no family history of similarness during this period. On examination in emergency, she revealed poor responsiveness. Her GCS was E2V1M56, and she had an iatrogenically dilated right pupil, and left pupil was 2 mm reacting to light. Paucity of movement of left side of the body, upper limb more than lower limb was appreciated, and there was intermittent decerebrate posturing with brisk reflexes, and bilateral extensor plantar responses were noted. The heterogeneically dilated right pupil showed grade 1 papilledema, but there were no meningeal signs. So for this acute, rapidly progressive encephalopathy with features of raised ICP and left hemiparesis, we started her on osmotherapy and empirical antimicrobials, and initially keeping a clinical possibility of acute encephalitis syndrome with left hemiparesis and raised ICP. She had come to us, she had already gotten an CT done outside, and then we repeated an MRI. Patient had worsening during the ward stay. She had sinus bradycardia, drop in GCS, and the anisocoria was persistent. So a decompressive craniectomy was done on 19th November, and biopsy from the lesion was also taken.
Okay.
We extubated the patient today. She is
Okay.
responding to all the comments. Anisocoria has also improved, and bradycardia as well. She
Okay.
persists to be non-verbal, sir.
Okay.
Imaging.
Yeah. Okay. So I think this for the clinical thoughts at the time of presentation. I think initially. So thinking of viral encephalitis, cerebritis, meningoencephalitis, post-infectious and possibility of CNS vasculitis. I will go to the CT. This is the CT done before the surgery, and it's a non-contrast CT, if I'm not mistaken. And you can appreciate there are some mixed density lesions, especially in the peripheral regions of the frontal lobes on both sides, along the falx cerebri over there, and also I think posteriorly you can appreciate here in the posterior temporal lobe. There's another hypodense region. Some areas of hyperdensity are seen within these regions, possibly suggestive of some degree of hemorrhagic changes along the likely along the sulcal spaces and the cortex. And there's diffuse edema. You can appreciate there's effacement of the sulcal and visceral spaces in the supra and infratemporal brain. So with that picture, I think decompressive craniotomy was done, and then the child had an MRI subsequently. So MRI, I think, was before the surgery, right?
Yes, sir.
Right.
MRI was done
Yeah.
before decompressing.
All right. Sorry. Yeah. So these are the MRI images. The corresponding CT findings are better appreciated here. You have again mixed pattern of edematous changes on the diffusion various sequences. Some areas of restricted and vasogenic edematous changes again involving the bilateral frontal lobes, the along the falx cerebri, and also the left posittemporal lobe. And on the T2 various sequences, you can appreciate heterogeneous appearance. We have some areas of hypointensities along the lesions. And these are usually possibly suggestive of some degree of hemorrhage out there. I think SWI sequences should better highlight the findings. So on the SWI, you can appreciate diffuse areas of blooming, nodular confluent areas of blooming predominantly in the cortical regions and also in the sulcal spaces. Yeah, all of the lesions demonstrate these abnormalities on the SPW sequences, and some posterior fossa abnormalities also. We have the focal areas of hemorrhage out there, adjacent to the fourth ventricle, and also the posterior temporal lobe abnormality demonstrates these hemorrhagic changes, microhemorrhagic changes along the sulcal and cortical regions. We can appreciate the diffuse edema, so effacement of the sulcal spaces, some mass effect on the right hemisphere and the basal ganglia, but no significant midline shift at this point of time. Post contrast, yeah, the nodular and the leptomeningeal enhancement in all the regions, again, more predominantly along the FARCs. Yeah, so yeah, on the axial images, these are the pattern, and you can again appreciate on the coronal sequences, yes, nodular areas of enhancement along with the smooth leptomeningeal enhancement out there. And dedicated angio or vessel wall imaging wasn't done. These are contrast sequences, and you can appreciate along the flowoids or along the areas of the intercalateral arteries and middle arteries, there is diffuse wall thickening on both sides. So some degree of vasculitis out there. And I think the changes also in the imaging correspond to a meningoencephalitis type pattern with some vasculitis changes corresponding to the hemorrhagic abnormalities on the sequences. So these were the imaging differentials kept, and the child was data evaluated. Yeah, over to you, Apurva.
Initial presentation, she already had some investigation done outside. Nothing significant other than there was some lymphopenia which we saw with elevated CRP. And then we did her CSF. She had pleocytosis, which were lymphocytic predominant, and there was elevated protein. We worked her up. We did her CSF, TrueNat, multiplex PCR panel. The organisms which are covered are being shown here, which all of those were negative. CSF for KH mount came out to be negative. CSF gram stain culture was sterile. Serum galactomannan was done. That was also negative. For vasculitis, some primary systemic vasculitis, we did the Cianca, Pianca, NA negative, which all were negative, and C3, C4 were normal. We have gotten the provisional biopsy report as well.
Before biopsy, some questions about cytokine storm and HLH, if that was covered or done, and HIV.
Sir, HIV was negative. And sir, what was the other question?
HLH workup, cytokine panel?
No, sir, HLH, no.
Okay. All right. So I think with this picture of investigations, they went ahead with a biopsy of the right frontal lobe lesion. And these are the findings. So what they mentioned is the tissue contains inflammation with endothelial injury with fresh fibrin thrombi. No evidence of granuloma, necrosis, fungal profile, parasite, or atypical lymphoid infiltrates. Suggestion of cortical vasculitis, parenchymal edema, and acute inflammation with ischemic changes in the neurons. So this was the biopsy report. And anything specific here, Dr. Apurva, you want to ask from the panels or to the audience?
Any fungal culture sent on the biopsy?
Yes, sir. Fungal culture has been sent, but the report is yet to come.
Yeah. Okay.
The pathologist, however, could not find any element of fungal. We asked them to look for it specifically.
So any comments on the case? Anything else to be done? That will open and also the,
I just wanted to ask, Lokesh, telling up about, whether you people give steroids like low dose, high dose. Usually, how do you deal with such situations? With CSF count was 200 and it was primarily infectious only. We covered like antibacterial, antifungal, and all. So, how do you go about it?
I think with the kind of hemorrhages and this one, fungal should be one of the prime differential here, irrespective of whether you get something at this point in time. Unless you have another organism, we should treat for fungus here.
Do we treat it with steroids, high dose, or like for vasculitis part, do we look into it, or just infection part?
Infectious part, I think I would be betting on the infectious part at this point in time.
Yes. Okay. Thank you.
Unless you have a strong evidence for that.
Yes. Thank you.
You saw activated microglia, any perivascular infiltrates. I don't think was mentioned on the biopsy. Vessel wall imaging could be done.
We haven't done vessel wall imaging.
Yeah, I don't think it's required. If you see the vessel wall imaging, this is what the flare contrast demonstrates. You have the thickening of the vessel wall. So it's a separate sequence. I don't think it's required. So it's infection with secondary vasculitis radiologically, as Dr. Lokesh mentioned, fungal, because it's about the diffuse hemorrhagic changes. That was the prime consideration, I think, that when the child presented. So we'll have to await fungal cultures. Is that right, Dr. Chika? Or
Yeah,
anything else?
no, I mean, yeah, thank you.
Okay. But HLH workup, if you, usually
Actually,
it
there was
is,
no acute systemic involvement,
yeah.
so we didn't consider it as a prime
Okay.
possibility. And
Okay.
primary CNS HLH also, yeah, we could have considered, but we have.
Yeah. Okay.
But no posterior fossa lesions here, isn't it?
Only one small foci, but yeah,
No.
there are no lesions per se. It's predominantly supratentorial.
Yeah. Thank
Okay, so I think we'll treat for infection and wait for the culture. Okay, we'll move on to our next case then. Pura, over to you.
A 3-year, 2-month-old, premorbidly well, developmentally normal girl child presented with fever of 20 days, and which subsided, and then it was followed by 10 days of altered sensorium. The child was well until 18th of October when she developed fever. And 2 days later, parents noticed that child had a brief episode of blank staring with the neck deviation towards the left side. And this lasted for a few minutes. And this was followed by excessive sleepiness. She was taken to a nearby hospital and she improved after IV fluids and anti-seizure medications. And she was discharged after 36 hours. The child returned to her baseline state. She was active, playful, doing her day-to-day activities normally. When from 30th October, she again became progressively drowsy with reduced responsiveness, and she was evaluated outside for some days, and then she presented to us on 6th of November. On admission to us, she was drowsy and intermittently opening eyes spontaneously, localizing to pain, producing incomprehensible sounds, and showing spontaneous limb movements. However, we noticed that she had microcephaly, but there was no, her perinatal history was absolutely normal and developmental history was also normal. The tone was normal, power was also more than 3/5 in all limbs. Formal examination could not be done because of altered sensorium, and plantar responses were bilaterally extensor. There were no meningeal signs, and systemic examination was normal. Initially, we thought of infective inflammatory non-aggressive status epilepticus possibility, and we did a sleep EEG, which was normal. For her, in all the infectious workup that we did came out to be negative initially, and her encephalopathy was persistent. So, considering inflammatory or immune-mediated process, we gave her IV methylprednisolone, but there was no improvement, and later IVIG, because she was not improving, but the child did not show any clinical improvement, and the parents took the child home. They did not want to continue. We counseled them for further immunomodulation. They did not want to continue the treatment.
Okay, we'll come back to it after the images.
Yes,
okay.
No.
So initially, I think there was an external scan done on the 1st of November. These are diffusion ADC sequences. You can appreciate some patchy areas of restricted diffusion in the brainstem, particularly the dorsal brainstem out there, and some areas in the central regions of the brain, especially the midbrain and the basal ganglia and thalami. Some cortical abnormalities in the perisylvian region, and some white matter changes in the centrum semival and the superficial white matter. On the, I think the T2s and the flares should better appreciate the other findings. Yeah, so again, multifocal abnormalities involving the supratentorial and infratentorial brain, white and gray matter structures on both sides. No corresponding changes of hemorrhage or blooming on the stabilized sequences. Optic nerves look relatively okay based on these sequences. No, it's not thickened or edematous. So yeah, these were the main findings on the flares, and I think initially thought of infectious or post-infectious demyelination, and the workup was done. Yeah, over to you.
is in the MRI that was done outside on 1st November, it was reported as normal. So we went ahead with our workup. CSF was showed only mild pleocytosis of 10 cells, which are 100% lymphocytic, and sugar and protein. Sugar was 16.2 and protein was almost normal. And culture sensitivity, CBNAT and multiplex PCR were all negative. Sleep EG record was normal. We also thought of some metabolic causes and did serum ammonia and lactate. However, lactate was only slightly elevated, and serum ferritin was also normal. Then we went ahead with the MOG panel and CSF autoimmune encephalitis panel, which were negative. And we did the repeat MRI brain at AIMS. We got the
Okay.
MRI reviewed. And
Okay,
yes,
I'll
sir.
show the MRI.
Yes, sir.
So repeat MRI done 2 weeks, approximately 2 weeks later. In terms of different abnormalities, again, similar changes in the brainstem and also in the thalami. But I think the rest of the findings have slightly progressed. You can appreciate now there are more confluent abnormalities in the frontal white matter and also the subcortical cortical regions. More confluent abnormalities in the deep brain nuclear structures and also the brainstem. So in terms of imaging, there is progression of the findings compared to the first scan, and as interval reduction in the volume, this is possibly related to immunomodulation. But in terms of the abnormalities and signal changes compared to the first scan, there is some degree of imaging progression out there. And on the SPINacademic sequences, no areas of abnormal blooming on the SPINacademic sequences. Midline size does not demonstrate any significant herniations or abnormalities out there. And on post contrast, there is no enhancement of the lesions or the abnormalities demonstrated in the suprainfantile brain. So with that, I think the question arises is, are we still dealing with an ITAS spectrum or autoimmune encephalitis, possibly seronegative demyelination, or do we need to consider any neurometabolic conditions based on the follow-up scan and the child is not improving on immunomodulation and also progressive changes on imaging? All right. So for mutation, mitochondrial NUBPLRS2, okay. Do we have a repeat? I mean, any other labs done? Puru, I mean, I think lactates
Sir,
are repeated, no?
lactate, the highest lactate, serum lactate, we reported it twice, did it twice. First was 7 and then repeat was 4.9. And yes, sir, there was hypoglycemia. And we have done CSF measles IgG, that was negative. Genetic test we could not do. EG was normal.
SERPAL mutation, brainstem, okay, but I think the multifocal abnormalities, I think maybe less likely. Dr. Gauri says that. RARS2 with spinal lesions, RARS2 more of a tRNA disorder, so maybe corticospinal tracts will be more involved. Mitochondrial presence with multifocal abnormalities. Japanese B ruled out. Dr. Nilu asks, I think let's see if it is covered. Jab B, no, I don't think Jab B
Japanese is not covered in this panel.
Biotin thymine levels?
No, sir, we haven't done those.
Actually, we wanted to do further metabolic workup, but it was like initially it was more of like ITS versus metabolic disease. And later on, we wanted to do this metabolic, but we cannot do because of logistics and the child was. Yeah, so the main issue was, to how to hold your horses when you have one probability of ITS and then another is of these things. But like the answers are also lies there that maybe no immunomodulation response to immunomodulation initially, and yeah. But I would like if somebody want to add on to this, they would have done something different or.
MRS, Dr. Ayush said, yeah, what is there, but unfortunately wasn't done.
I think majority of these
Hmm.
comments are for mitochondrial this thing. So
Okay, may not know that. Yeah, low sugars. Yeah, biotin deficiency can have late. Yeah, biotin, I mean, I would agree. Low sugars would not agree. Anash says low sugars with multiple persistent progressive lesions, more infectious, but cell is not responding. Is that a do all infections respond or not? Yeah, sure. Okay.
so maybe if the child comes back, we'll they said they will come back, so we'll send genetics and maybe
Okay.
update you. Yeah.
Yeah,
Thank you.
that should be
Thank you so much.
okay. All right, Razi, over to you.
Good evening. So this is a 4-year-old child, a boy, presented initially in infancy with vision-related issues. Around 7 months of age, there were no developmental concern during that point. Initial thought of CVI with nystagmus, but around 2 years of age, he had developmental delay, cruising around and not walking independently. And around 3.5 years of age, a child was walking on toes, walking with both hands held, and strong stranger anxiety was there. Born to third-degree consanguineous parents, uh, no perinatal issues. On examination, head circumference was 44 centimeters, microcephaly and horizontal primary gaze nystagmus was there, as well as poor truncal balance and taking a few steps with both hands, and central hypotonia and spasticity of gastrocnemius was there, and child was walking on toes. So initial differentials based on the history, motor global developmental delay with primary sadness, differentials were hypomyelinating leukodystrophies or
Sorry.
hypomyelinating leukodystrophies and any glutaconic aciduria, OPA3 kind of thing, or any mitochondria. So initial during first 7 months of age, during that time, MBS was done, which was normal. Flash VT was uh, Flash VT was normal, and EG was done initially, which was normal. And because of the developmental delay, whole exome sequencing was sent, which showed three variants. Initial NUP6-2, which was homozygous autosomal recessive, but it was segregating in one of the asymptomatic parents. And SED-D2 and SRM2.
We can tell the genetics later after the radiology.
Yes.
Okay. Yeah, we have three sets of images, all external scans. This was at 10 months of age. I think the first panel is a diffusion weighted sequence. Then we have T2s and T1s. So you can appreciate the concern changes on the DWI sequences. I don't have ADC to see if it's T2 shine through or true restricted diffusion, but confirmed abnormalities in the cerebral white matter. On the T2 weighted sequences, also at a rate of 10 months, we have some degree of delayed myelination. The antilimbical capsule is not myelinated. The paracentral white matter is not myelinated. Central semioval is not myelinated. Subcortical, occipital, and parietal white matter also is not myelinated. Some degree of delayed myelination with confirmed abnormalities on diffusion weighted sequences. No cortical malformations at this point. And on the SAT sequences, you can appreciate thinning of the corpus callosum. For a 10-month-old, this is reduced in caliber. I think optic nerves were done for CVI, but there's no optic nerve abnormality. Some kinking out there that this can be a normal variant. But yeah, no significant changes in the optic nerves. So at this point of time, some delayed myelination, some mild hyperplasia of the corpus callosum, and those diffusion changes seen on, we don't have an ADC, but yeah, they are present on concurrently in the bilateral hemispheres. Follow-up was done, I think 2.5 years, 2 years later, and you can still appreciate if you focus on the T280 sequences. Again, the myelination has not caught up. Again, you have delayed myelination or hypomyelination, especially in the septum semiovale, the paracentral white matter, subcortical parietal white matter, and also the anterior limbs are not completely myelinated. Yeah, so some degree of myelination in the posterior ligamental capsules around the corpus callosum, but you can appreciate that there is some degree of unmyelinated brain and also some interval reduction in the cerebral brain volume. In terms of diffusion changes, there are no diffusion changes at this point of time, and flare you have some hyperintensities, predominantly along the periventricular regions. On the SAT sequence, again, you have further reduction in the volume of the corpus callosum. Rest of the findings we have demonstrated on the axial sequences and no corresponding blooming to suggest calcification or hemorrhage in the supra and temporal brain. Yeah, another scan, again done 8 months later. And again, you can appreciate a similar pattern of appearance as you have seen in the prior study. There's some degree of hypomyelination out there. Yeah. So dealing with hypomyelinating disorder. Again, diffusion did not show any abnormalities, and yeah, there's again thinning of the corpus callosum. So no additional changes in terms of the prior study. The spectroscopy was done. I think did not demonstrate any significant findings. So there's mild lactate peak out there. Inverted lactate, yeah. There's mild inverted lactate, but the rest of the peaks are not significantly abnormal. Yeah, so with that, I think the radiological thought was hypomyelinating disorder, and I think the child was again evaluated for the same. Yeah, Razi, okay.
So initial first three set of genes which came as VUS and not matching the phenotype. NUP62 was a partial match, but not a complete match. Only vision related issues. But SCTD and RM2 was not a match, and the genes were segregating in the parents as well. And the parents wanted to plan the next pregnancy. So we went ahead with trio analysis and based on the again repeat MRI features as well, mostly looking like hypomyelinating leukodystrophies. In trio analysis, we could recently we got the report as RAS1 homozygous in child. Both were segregating in both family members, heterozygous in both parents.
So it's slightly pathogenic now, Razi? Positive?
Yes,
okay. So then we went and looked at the literature, and the findings are what I described are predominant changes are hypomyelination with brain atrophy, and what we are seeing in our case also there's hypomyelination with interval reduction in the brain volume. So these are two series of published cases of the RAS1 related leukodystrophy, and you can appreciate that there are findings are somewhat similar to our case. So I think radiologically it's a match, and as genetics also you have pointed out, Razi, the gene is positive. So I'll open the case if anyone has similar experiences or any alternative possibilities still when the genetics and radiological abnormalities.
I have no experience, but it's a good match. History, MR, genetics.
Thanks, Hagen. Anas asked initial first scan, is it too, I'm not sure, Anas, I need ADC, so. Let see then, Dr. Isha, I think before the genetics, thinking of hypomyelination, but yeah, possibilities have been listed. So yeah, it's a clinical and radiological match. So we'll go with the RAS1. Just wanted to highlight the case.
Yes, angle sequencing later trio analysis have given the answer.
Yeah, and the other genes, they're all not related, at least imaging wise not related, and two of them present with intellectual disorders. And NUP62 has more striatal and ankle involvement, which was not seen in our case. Yeah, so these are known now. All right. Next case, Apura, what do you?
Yes, sir. So this is a 2-year-old boy born of a non-consanguineous marriage. They are from West Bengal. So this child had mild developmental delay initially. At 15 months, he was still cruising around furniture. He had not attained independent walking, and speech he had bisyllables. At 15 months and at 20 months, there were two episodes of fever triggered regression, motor much more than cognitive regression. So during the first episode, when he had the CRTI with fever, he had lost his neck holding rollover. Irritability was there for some period, but it had improved, and they had noticed there's some squint and loss of speech, but the recognition of parents was present. So motor and speech was much more affected. During this 6 month period between 15 month 5 month period, 15 and 20 months, there was some improvement in neck holding after the acute episode. But over 5 months, there was plateauing. There was no new attainment of the motor milestone and speech as well. Cognitively, he was only recognizing and smiling to parents. Second episode happened at 20 months. Again, he now, after had a fever triggered regression and lost complete neck holding. And now parents noted that there is some tightness of the limbs, which was present, as in putting diapers, it was a little more difficult. And cognitively, again, the child was much better than motor, and but there was no improvement in the speech, and squint had persisted. There were no issues with hearing. So clinically, there were two episodes of fever-triggered motor more than cognitive regression, late infantile phenotype. So possibilities of mitochondrial disorder or vanishing white matter disorder was considered, and another possibility, though because it's very acute, but INAD because motor more than cognitive was one differential. So this is the scan imaging.
Oh, sorry.
Yeah.
Yeah.
So for the on examination, child had head circumference 48 centimeters, short stature was there, less than third centile, but weight was appropriate. Just low set ears, but no other dysmorphism, normal hair, no cutaneous markers, no wasting, no distal wasting of the limbs, bilateral non-paralytic right more than left esotropia was there. Cognitively, he was giving social responses, smiling. On attempting to reach, there was dystonic posturing, striatal too, and axial hypotonia was there, and mild catch at gastric nemes was there. There was hyporeflexic ankle, but there was no wasting, there was no contracture, no weight bearing, but good anti-gravity movement. So possible localization was something which is involved the white matter, and because of the dystonia and striatal toe, some basal ganglia involvement.
All right. Thank you. With that, we'll go on to the images. Again, some external images, maybe slightly pixelated and hazy. But if you go on to the top panel, you can appreciate there is cerebral volume loss, widened fissures, and foveal spaces. The cortex also possibly appears slightly bright on the T280 sequences. Coming to the top, yeah, you can appreciate the the cerebral atrophy in comparison to the normal cerebral volume. But there are some hyperintense changes along the bilateral basal ganglia, especially in the globus pallidi out there. And some superficial cortical volume loss in the frontoparietal lobes. On the SAT sequences, again, I have a zoomed in picture. I'm not sure how clearly it projects, but there's clever hypertrophy out there with some degree of pontine hypoplasia, corpus callosum hypoplasia, and cerebellar atrophy. On the diffusion various sequences, you can appreciate that the bilateral striatal nuclei demonstrate restricted diffusion. Look at the, I mean, if you better appreciate on the ADC sequences, and also some degree of restricted diffusion along these post-thalamic nuclei and the middle temporal lobes. So with these findings, radiologically, thinking a possibility of INAD, given the clavicle hypertrophy and the bright cerebellum, cerebellar atrophy, list of differentials, two papers extensively covered by Dr. Bolthauser out here, and but the main findings out here that the clavicle hypertrophy and also the basal ganglia changes. We had discussed similar findings in previous meetings. So these are posterior force abnormalities are typical for INAD. You have cerebellar atrophy, bright cerebellum on the cortex, and also clavicle hypertrophy. Over a period of time, you can have mineralization in the basal ganglia, and these transient edematous changes are known to be present in especially in the basal ganglia and the brainstem in INAD-related cases. So both of these were INAD positive cases. So I think we're moving towards the possibility of likely diagnosis of INAD. And I think genetics was done.
Yes, sir. So this child had PLA2G6. INAD was the neurodegeneration. INAD was the finding, and it was segregating in the parents.
All right. This is open. Any comments? Similar experiences?
I think it's a very good match, clinical-wise, imaging, and genetics. Just a minor point, of course, you have to consider everything in the context. A prominent clava can be seen also in Joubert syndrome, and I have seen it repeatedly in NF1. I mean, you would not mix up that, but just not only look at the clava, but the overall picture. In INAT, you also have usually later optic atrophy.
Yeah. Thanks, Amy. Call it vertically oriented splenium. You mean the drooping splenium? I think that's non-specific. It's related to maturation delay. I'm not sure if it's specific to INAD. There's a paper by, I think, Sikit's group in 2008, where they mentioned this splenium, drooping splenium with maturation delay, not specific.
Yeah, I agree. Radiologically, this is the first clinical which I have seen with worsening with recurrent illness. I have seen a few INADs, but they have been having global delay, microcephaly, and unexplained thing. This worsening with intercurrent illness is the first time which I am seeing. Good learning.
Clinically, it was a very different, like we were not considering it as a differential, but radiologically, and then.
Yeah, clinically it's a bit difficult. Yeah, but radiologically, I agree. Bang on.
I think the basic ganglia changes were slightly, as Anas mentioned, but as highlighted out here, we had two phases, I think, last year itself from Rainbow. Both of them had transient changes, and it is a well-described finding in children with INAD. So differentials can be mitochondrial disorder with cerebral atrophy, Wilson's disease, but the caval hypertrophy is not seen in those two disorders. Methylglutaconic aciduria also can have basic ganglia abnormalities with cerebral atrophy, but again, label hypertrophy is not seen. So the constellation of all the findings, I think, points towards INAD radiologically. All right. Yeah, with no comments, I'll move on to our next case. All right, Razi or Harika, what do you? Razi, if you're speaking, you're not audible.
This is a 7-month-old girl born out of non-consanguineous marriage. First in birth of the 3.5 kgs, no perinatal issues. History of developmental delay, gross motor partial neck holding is there, partial rollover, sitting with support, still not retained. Fine motor does not reaching out for object, hold object when placed in hand. Speech, only cooing is there, no social smile, no fixing and tracking. Response to name call is inconsistent. On examination, roving eye movements are there on hypertelorism, smooth philtrum, no light perception, no fixing and tracking, no reaching out for objects, and not localizing to sounds. No startles, but arching and oromandibular and limb dystonias are there. As well as hamstring spasticity, grade 2, and biceps grade 1 spasticity. Good anti-gravity movements, pull to sit, minimal head lag, and truncal weakness was there. Weight bearing on toes with inversion on right side.
Anything on the video, Razi?
Some oromandibular dystonias.
Okay.
And mild arching and startle.
Okay. I think with that, this child had an image at not mistaken, at 4 months of age. Yeah. At 4 months of age, these are the imaging images, T2 axles out here. You can appreciate there is some degree of reduction in volume. I thought reduction in volume of the basic ganglia, especially the putamen. They appear slightly hypoplastic. In terms of myelination, the ventral pons should be myelinated, even on the T2 sequences. That is not myelinated. Corpus callosum, again, the splenium should have been myelinated. That's not myelinated. So some degree of delayed myelination with possibly hypoplasia of the basic ganglia, especially the putamen. On diffusion, no abnormalities on the DW sequences. On the T1 weighted sequences at 4 months, I think the anterior capsule again not completely myelinated. Optic radiation also, especially on the right side, is not as bright as what it should be. Again, ventral pons is not myelinated. So some degree of delayed myelination radiologically at 4 months of age with some hypoplasia of the basal ganglia. We thought of possibility of TUP4A mutation or UFM related mutation, but we thought Follow-up scan at 6 months, follow-up scan after 6 months or close to 1 year of age would be more diagnostic imaging wise. Yeah.
Nihaal, I missed the
Yes.
point. What about the optic nerve? Could you have a look at the optic nerve? Because in terms of basic teaching, this child has roving nystagmus, which means the problem is in the anterior optic pathway.
Got it.
This is not CVI.
Yeah, not severe. I think the optic was normal. I don't have the images, but yeah.
Thanks.
And then I think after the MRI scan was done, the child was evaluated for a genetic disorder and Razi-OT.
Yeah, EG was done, which had a normal background and good sleep spindles, no interictal discharges. Initial metabolic workup, TMS and urine GCMS and lactate and homocysteine were normal. Optal evaluation showed a small optic disc with temporal pallor, an anomalous optic disc with left temporal crescent in right eye, and retinal pigment epithelium showing mottling in August 2025. So whole exome sequencing was sent, which showed SRD5A3, one of the phenotype of congenital disorder of glycosylation type 1, which is autosomal recessive pathogenic variant. Transferrin isoelectrophoresis was sent, which showed the type 1 pattern.
So pathogenic and positive to conclude, Razi. So imaging wise, I don't have any reference for imaging. I think this is one paper was published, but they don't have any images. What they mentioned in terms of neuroimaging findings was possible cerebral atrophy and vermis malformation. Very non-specific, not sure of that. Optic atrophy is highlighted here in majority of these cases, and other skin and dermatological abnormalities and hematological abnormalities as pointed out here. As Razi has mentioned, transparent is abnormal, also seen in our case. So radiology wise, the literature is very limited, but I think clinically it matches, if I'm not mistaken. Razi, is that right? Okay, Dr. Ayush says, yeah, isoelectric focusing was important in this case. Thanks. Okay, I assume that imaging wise, I don't think we have any previous or any experience with this gene. But at least in our case, at 4 months, there was delayed myelination with some hypoplasia of the putamen, commonly seen in top 4As, but yeah, spectrum is, I think, widening. And there's no cerebral atrophy, which is again commonly seen in HABC. So yeah, that was again a negative finding. But on the follow-up, it might be there. So yeah, no one else any seen a similar cases or experience. We'll move on to our next case. We just wanted to highlight the importance of isoelectrophoresis.
There was no inverted nipples or any abnormal pad of fat as well.
So is that seen in all the CDGs or just type 1A? This was type 1Q, I think.
This is type 1Q.
Yeah.
Extremely rare, I think.
Yeah.
And just as a reminder, the isoelectric focusing is not meant to be reliable in the first 4 weeks. And it has to be done in serum and not in plasma.
First 4 weeks of the illness or first 4 weeks of?
4 weeks of life.
All right. Okay. I think this was done later on. Yeah. All right. Yeah, I think a pretty rare case. So we just wanted to show that. With that, I'll move on to our next case. Harika or Razi, over to you.
So this is a 3-year-old girl born to non-consanguineous, third-degree consanguineous parents. History of neonatal seizures on day 2 of life. Had hypoglycemia. Then again, seizure recurrence happened around 2 weeks of life in clusters, requiring hospitalization. And since then, she had multiple episodes of seizures till 9 months of age, which was equivalent like jerking of hands and legs, with facial twitching as well as perioral automatism associated with cyanosis, which was lasting for a brief duration. Last seizure was febrile seizure around 10 months of age. It was generalized motor seizure and which lasted for 1 minute duration. Since then, child was seizure free for about 2 years. Development-wise, independent sitting around 1 year and full to stand around 1.5 years and independent walking around 2 years. So there was developmental delay. Then she had regression in around 2.5 years, like walking and sitting independently was lost. Only when made to sit, she was sitting, W sitting with support. And fine motor, she was able to scribble and she was playing with peers and bisyllable was there, but with normal vision and hearing. No perinatal issues. Initial based on the history, there was motor more than cognitive delay, and then motor regression onset around 2.5 years. Onset seizures, which persisted till infancy. Initial differentials.
Sorry.
Based on motor more than cognitive with thought of lipodystrophies and hypomyelitic lipodystrophies, and with regression with thought of any mitochondrial related or developmental epileptic encephalopathy. And head circumference was 47.5 with around between third and 50th centile. Had spasticity in spastic diplegia phenotype. Lower limb was more involved than upper limb, and some dystonic posturing in upper limbs were there. And adductors were more spastic than hamstring and gastrocnemius. There was weight bearing on toes, and scissoring was there, and genuine curvature with paraspinal weakness. Initial investigations in 2023, which were NSG was normal and EEG printed record showed left occipital spike wave discharges, and MRI around 6 months of age was reported as normal. And repeat EEG, which was done in June and July 2025, there were also printed record near continuous discharges suggestive of epileptic encephalopathy.
Right. With that, I think we have an imaging, latest imaging. This was done a few months back, so at around 2.5 years of age. Supratentorally on the T2 axils, no cortical abnormality, no malformations, no signal changes in the deep brain nuclear structures or central white matter or periventricular deep white matter structures. Coming down to the posterior fossa and the brainstem, you can appreciate these linear areas of T2 hyperintensity, possible tiny areas along the posterior luminal capsule along the posterior aspect. But the main findings are in the brainstem. You can appreciate that these linear hyperintensity is going through on both sides, involving the midbrain, pons, and also the ventral medulla. Coming down, if you look at the axial image of this spine, you can again appreciate lateral and ventral corticospinal tracts also demonstrate these hyperintense changes. On the side sequences, the extent of involvement can be better appreciated, especially from the medulla cervicomedullary junction and also involvement of the upper cervical cord. So these were the main findings on the T2 axial sequences. On the flare sequences, again, you have these corresponding changes. The plic abnormalities are better appreciated on the flare sequences. You have these areas of symmetrical hyperintensities in the posterior aspect of the posterior luminal capsule. Again, brainstem abnormalities as what we have already seen on the T2 sequences. There was a comment of posterior periventricular white matter changes. I think these are more likely terminal zones rather than abnormalities. And on post contrast, you have these punctate areas or focal areas of enhancement along the pontine abnormalities. Spine was sad spine was done. Only axial cervical cord was there, which I mentioned that there was abnormalities along the ventral and lateral corticospinal tracts. With that, at least the imaging differentials predominantly affecting the corticospinal tracts or pituitary tracts. These are the possible considerations: paroxysmal disorders, bifunction protein deficiencies, the AMN variant of ALDs, and other differentials as highlighted out here. Yeah, so these were the imaging possibilities or the imaging considerations of based on the imaging of this child. TRN disorders, I think, as we had mentioned, but yeah, child was evaluated and
So HSD 17 before exon 14 came as homozygous autosomal recessive nonsense variant, the bifunctional protein deficiency, which was clinical match. I think, and VLCFA have been. It is the paroxysmal disorder involving hydroxysteroid 17-beta dehydrogenase bifunctional protein, in which we can see hypotonia as well as spasticity and seizures and dysmorphism are the common. But children can present with hearing loss and vision loss. And VLCFA we have sent and parental segregation have been sent. Those reports are expected.
All right. So retrospectively, this is the abnormality, and you can appreciate similar findings seen on the first two set of images. So paroxysmal deep bifunctional protein deficiency can have selective involvement of the corticospinal tracts over a period of time, can have atrophy and more widespread involvement of the cerebellum also. Yeah. So
the findings are age dependent. Some of the
Yes.
images in the publication are later on.
Yeah. I think polymicrogyria can also be there, but that wasn't seen in our child.
Yeah.
Yeah, RSACs, okay, there will be T2 hypo and LBSL TRN disorders, I agree, differentials possibly.
And RSACs has cerebellar atrophy.
All right. Yeah, it's a good clinical and neurological match, and we just wanted to, again, widen the differentials for corticospinal tract involvement imaging-wise.
A very rare fetal disorder in which we can see elevated C26 and C24 by C22 ratio at VLCFA.
All right. Thanks, Adi. With that, I think this is the last of the new cases. Ramya is there. Okay. Otherwise, I can take it. So this was a 6-month-old male child, initially asymptomatic, 10 days prior to presentation, but developed upper respiratory tract infection. And the child was taken to an outside hospital, started on HFNC and LFNC support for 3 days. Was treated with IV medication as listed out here. And the baby became afebrile with no respiratory distress, was shifted back to ward. Baby still had fever spikes with high ferritin levels, that is more than 2000. And with that, baby was shifted for further management evaluation to this hospital. So present illness, the history of past illness, the birth history was term gestation, born to non-consanguineous parents. Immunization history was as per schedule, and developmental history was there was partial head control with no complete rolling over or looking and recognizing parents. Anthropometry wise, weight was 8.4 kgs, head circumference slightly on the higher side, around 95th percentile. Vitals were normal. Other than the beep, vitals I think are normal. Someone can correct me. Systemic examination, I think nothing significant out there. The course in the hospital was child was admitted and had complaints as mentioned above. Baby developed respiratory distress for subsequently with vomiting, was shifted to ICU with HFNC support. VBG and other investigations were done. Antibiotics were given. Child had continued fever spikes. Responded to midazolam loaded with levetiracetam and NS solution. Lumbar puncture was done, which demonstrated a picture of viral meningitis. CHF-HSV was negative. Baby had high BPs. Subsequently, around 95th percentile, and oral amlodipine was started. IVIG and pulse steroids were given. Genetic workup was sent. We await the results. Baby subsequently had seizures, autonomic activities, and sensorium was slightly improved, but irritability also reduced. No further fever spikes since last 2 days. This was the condition at discharge, the vitals and the systemic examination. So with that, I think an MRI was done a couple of days back. And on the MRI, I think, not sure the age. Yeah, at 6 months, you can appreciate the white matter is swollen. You have these diffuse T2 hyperintensities out there. Capsular white matter is also involved. The internal limbs, the borders of the internal limbs are involved, especially the posterior limb capsules. Some shading over onto the T2 on the globus pallidus, but extensive white matter changes involving the bilateral cerebral hemispheres on both sides. Coming down to the cerebellum, again, you can appreciate some white matter changes in the cerebellar white matter and also the subcortical regions on the inferior cerebral hemisphere. On diffusion-weighted sequences, only a punctate area of restricted diffusion in the splenium of the corpus callosum. So cytotoxic lesion out there. For a 6-month-old, I think the corpus callosum is okay. There's no significant volume loss and no diffusion changes corresponding to the white matter abnormalities on the T2-weighted sequences. On the flare sequences, again, you have corresponding changes of flare abnormalities. as seen on the T2 sequences, diffuse white matter hyperintensities, and also cerebellar involvement, as we have seen on the T2 sequences. On the T1 sequences, there's slightly hypointense corresponding changes to the T2 and the player hyperintensities. Yeah, so diffuse white matter abnormalities, especially involving the supratemporal brain. So these were the. I think contrast also was done because there was a suspicion of viral meningitis, but there were no abnormal areas of enhancement, no meningeal enhancement, or no parenchymal abnormalities. Yeah, so we thought of possibilities, though the picture was of viral meningitis with high ferritin levels, possibilities of MLC, especially the MLC Clalcam variant, which does not have cystic changes, at least initially in the presentation. So, and the child also had macrocephaly. So these are the differentials for leukodystrophies and macrocephaly. Again, MLC fits, but these two variants have subcortical cysts, whereas the last one does not have subcortical cysts. We're thinking of genetic leukodystrophies as a possible consideration, but the question we wanted to check was, are the ferritin levels significant at around more than 2000, or any alternate possibilities need to be considered? So first, I think the corpus callosum change is due to cytokine storm, which was, I think, there in the child, but the rest of the findings do not corroborate with the at least the acute presentation. Okay, Khalid says MLC with cyst, there are no cysts, but I'm not ruling it out, Khalid. Yeah.
Can you show again your slide? I missed it. Your differential diagnosis. Would the gangliosidosis also be in the differential diagnosis?
In terms of leukodystrophy and macrocephaly, yes, I can, but basically, I would have appreciated more signal abnormalities, especially in the dorsal striatum. That was not there. And thalami, the ventral thalami, I think normally is slightly T2 hypointense, but those gangliosidosis are more diffusely hypointense. Not ruling it out, but I think
okay,
some features may not be there. Cardiac Guterres, two symmetrical no calcifications.
In L2 hydroxyglutaric aciduria, I would expect more involvement of the dentate nucleus.
Yeah. No, those differentials were more related to macrocephaly, because the child had 95th centile findings, and more subcortical involvement as with the dentate inhibitor. So we just wanted to check if all are thinking genetic abnormality or still a possibility of an acquired cause. Because you already sent for genetics, you can reverse phenotype it. And specifically, I wanted to ask the significance of the ferritin levels. Is that commonly seen in severe viral related infections, or we still have to look for primary CNS HLH, though imaging does not match?
This is very likely genetic.
Yeah, thanks, Hagen. I also, Prayesh also says, yeah, does not support.
The genetic investigation back?
No, it's sent a couple of days back. So I think we should get it in a couple of weeks. So since it's already sent, we'll update you with the diagnosis. All right. I think we have one follow-up case. It was a pretty complex case discussed a month prior. If Apura, you're there, you can just quickly summarize the case. The AIMS
yes,
Nagpur case.
A 16-year-old boy who was morbidly well, met with an road traffic accident on 18th August, and he underwent surgery for that. At that time, there was no history of any head trauma, and child was neurologically normal. He was mounting on and off fever daily at home, and in September he had an episode of seizure. That time he was worked up, treated with some antibiotics, and discharged as child improved. And Parents took the discharge on their own, and then child subsequently had a, increasing drowsiness, irrelevant talk, slurring of speech with complaints of blurring of vision, some headache, neck pain with paucity of movements of left side of the body, and inability to get up to sitting position on his own, along with some swaying while sitting, and not able to drink water on his own. There was history of suggestive of ataxia. And then the child presented to us. Initially, we kept a possibility of post-traumatic meningoencephalitis, as his CSF showed a very high cell count of lymphocytic predominant, and his protein was very high, and sugars were low. But we did CSF biofire, culture sensitivity, gram stain, everything was negative. And then we discussed the case here, and we got CSF
Okay.
metagenomic.
Okay.
Yes.
We'll come back to that after. I think I'll skip the
Yes.
initial images. We'll come to the most recent MRI. I think we have discussed this previously. You have this multifocal area of diffusion, cortical subcortical region, the frontoparietal lobes, also involving the deep brain nuclear structures, particularly the right vessel ganglia globus pallidus. A mixed pattern of edematous changes. As you can see, some of them show reversal on ADC, whereas some of them demonstrate facilitated diffusion. So confluent abnormalities, I think better seen on the T2 sequences. We have bilateral hemispheric abnormalities, peripheral regions also involving the central regions of the brain, white and gray matter structures, posterior fossa involvement in terms of the brainstem involvement, and also peridentate and cerebellar involvement as seen out here. On the SW sequences, the supratentorial lesions demonstrated areas of hemorrhage, macrohemorrhagic foci. The lesion out here in the right basal ganglia had this peripheral capsular areas of SW sequences demonstrating blooming, and some punctate abnormalities in the pons. On the post-contrast study, you had this almost perivenular perivascular type enhancement in the supratentorial abnormalities. The deep brain nuclear changes demonstrated peripheral ring enhancement, and some punctate nodular enhancement demonstrated in the posterior fossa structures. Yeah, again demonstrating the perivascular perivenular enhancement pattern with these peripheral areas of enhancement, more focal lesions in the deep brain nuclear system. Spinal cord was strained, and you had long segment myelopathy, particularly involving the central regions with some areas of patchy enhancement. Cardiac note also demonstrates mild enhancement, but yeah, these were the findings, and wide list of differentials were considered. We thought of infections, clippers, slippers, HLH, fungal infection, possibility of that was considered. I think the child, as Apurva will highlight now,
The
yeah,
child was deteriorating with empirical antibiotics. We tried to gave him antifungal, antibacterial, everything, and he was deteriorating. We went ahead with CSF metagenomics, and in this we got growth of two organisms, one fungi, Malassezia restricta, and another Cutibacterium acnes, but both were reported as commensals. And we consulted an ID specialist as well, and they were of the opinion that we cannot keep them as the causative agent. And then we requested our microbiologist to relook into the cultures, and they showed us growth of acanthamoeba species on non-nutrient agar in the CSF. So
and these are the imaging correlates. Yeah, hemorrhagic focal abnormalities, unfold abnormalities have been described in the granulomatous variant of amoebic meningoencephalitis. So I think retrospectively the imaging matches. Any risk factors here for the child?
other than
For
trauma, and other than trauma, there is no other risk factor that we could find. That was a very high intensity trauma with a high motor vehicle, and the rider of died on the spot. He was a pillion rider. He survived and had many surgeries.
Yeah, so no Okay. I think retrospectively it matches, at least the imaging matches now. But we thought, at least at that point of time also, we thought that we needed a microbiological diagnosis.
Yes, sir, but the lesions were too deep. We had discussed with neurosurgery. They could not access it.
Unfortunately, it's child passed away, but I think we can close off the cases related to amoebic encephalitis. Any comments on that diagnosis or any similar experiences, cases of them? Kalidas, source of I'm not sure of the source. All right. Retrospectively, I think radiologically, it's possibility to have the amoebic encephalitis, especially the granulomatosis variant. But usually, are they rapidly progressive, the amoebic encephalitis ones? The child, I think, over a period of 2 months or 3 months, right? Hospital stay ends.
Yes, sir. The trauma was he started having neurological symptoms a month around about 3-4 weeks after the trauma, and then since then he has a progressive illness. And he passed away 1.5 months later after the onset of neurological symptoms.
In Giants is rapidly progressive usually.
Yeah, I think the progression is the only thing which
of course.
we never actually very much sincerely considered amoebic, because it doesn't look like very rapid progression and also. But this is what we have learned from this case.
Yeah, and also initially, I don't think the extent of lesions were as maybe we expected to see. Some focal abnormalities here, but if you look at the most recent scan, there was progression in terms of imaging wise, but at that point of time, it was very difficult to point towards amoebic encephalitis. So thanks the Nagpur team for closing the case and enlightening us with the diagnosis. Unfortunately, the child has passed away. If there are no comments, any comments or sir? All right. If there are no further comments, I think that is our last case. Okay. Thank you. I think next session, we'll let you know when is the next session. I'm out of station for the next one, but we'll schedule it and let you know via the email or you'll get a notification. Thanks for your time and thanks for the cases and the chat to be active and all your suggestions. Till next time.
Bye. Thank you.
Bye again. Take care. Bye-bye. Manager, you can stop the session.